Hello, I'm Dr. Rafi Romano from Israel.
And I am Rafi Romano, also from Israel.
I'm truly sorry I couldn't come to the WSLO meeting in Thailand this year, but I've decided to send you my recorded video so you can feel as if I'm sitting with you in the whole room.
I will be part of this lecture trying to see what's right and what's wrong in what Dr. Romano will present. I want to thank my friends, Dr. Amon Fong and Dr. Professor Himong Kyung, for inviting me to this program. I'm really honored, and I think they've built a wonderful program which I'm sure you will all enjoy. My lecture today will concentrate on CAD/CAM, on digital tools that we have today in our office. This includes both clear aligners that we have today, the CleanCheck by Invisalign. We have other softwares to align teeth and to produce aligners, and we have bracket digital options like Incognito, Win, Harmony, Insignia, and the Sure Smile, which is a combination of both the digital planning and the digital manufacturing of wires. Most of us have today scanners in our offices, so we can work completely digital, scan, plan, manufacture, and interact with all our colleagues. What do you say, Rafi, about it?
You know, Rafi, I don't agree with you, because I think that we can use all the tools that we are used to do for many, many years. I can use all the bracket positioner, the TARC, the wonderful laboratories that are spread out all over the world, and many of them are attending in this room, including Peter Sheffield and Aris Kiyaka and others, who can place the brackets and position them in the perfect place, and then get a tray, and then with a chart that already developed for many, many years, knowing exactly what to do, either buccal or lingual orthodontics, with exactly the number of torque, angulation, and inclination for every tooth, including the overcorrection that we need to do in order to align the teeth. You can see this beautiful case of this beautiful lady that had some crowding, had some inclination of her upper incisors, which, as we know, is not easy in lingual orthodontics because of the short interbracket distance. But if we place the bracket properly, then very easily we can have the case finished in not longer time than usual. You can see the roots parallel, you can see the occlusion, you can see how beautiful it is, and I didn't need any CAD/CAM. So why we need CAD/CAM?
You know, Rafi, you are definitely right. We have done a lot of cases beautifully, and I think I will continue to use laboratories in the future. But I think the digital tool give us a lot which the regular tools cannot give us. You can see, for example, this case which came to me, this is a buccal case, but you can see that when we use our digital tools, we can see that by CBCT and combining a program which combined the scanning of the face and the CBCT, we can see that although the roots look quite parallel and the case look acceptable, then when you look at the animation of the CBCT together with the 3D software, we see that all the roots are outside of the bone. How could we see it if we didn't have all these digital tools with us? Look, for example, in this case. This case I've done in a completely digital way, interacting with the periodontist. This case is a 70 years old man who suffered from advanced periodontal disease. You can see that not only he's class 3 with anterior crossbite, he has also very, very minimal bone support, a lot of recessions, some mobility, and a lot of spaces. So this is a very big challenge for us. So I've used, of course, the dental records, the periodontal checkup for this patient, the team consultation, and I've planned all my case to do treatment for this periodontal case with Invisalign.
Well, Rafi, you know, it's worrying me because you are treating a periodontal patient, and we know that periodontal patients with orthodontics may get even worse. So how come you take such a patient, old patient with very, very minimal bone support, and you dare move the teeth, and you do it with lingual, which is even can get worse because we are close to center of resistance, and we are doing a lot of force on the root. I think I would be very worried. You know, Rafi, for every article I can bring you a different article, and there are articles who show that the attachment of the epithelial attachment and the contact between the tooth and the bone can improve after orthodontic treatment, mainly because you minimize the mobility, you minimize the trauma, you improve the angulation of the tooth, and you correct the bite in a way that there will be no further movement for these teeth. So, you know, the truth comes probably in between. We should be very careful, but not avoid doing treatment. You can see here how I plan this treatment. You can see the video showing all the teeth movement, but I think what is more important is not to see only this animation, beautiful animation, but also to see that we have planned that the movements will be very, very minimal in order not to damage all the roots and all the movement, to do it slowly by a lot of aligners. I've scheduled for this patient 45 aligners. Oh, you know, this patient, when the teeth moved from crossbite, moved further back, had edge to edge, and had some mobility. I'm sure you have to say something about it, Rafi. Oh, Rafi, you see, I've told you. You know, now we have edge to edge between the upper and lower centrals. I heard that he has a lot of mobility, and the mobility with the little bone support can damage the tooth, and maybe we're gonna lose it. What do you say? You are right, but this is why when you choose your appliance, and I prepared for this lecture one Invisalign case and one lingual. The Invisalign has a lot of advantage in periodontal case because the aligner embrace the tooth in all dimension, buccal, lingual, sides, and hold it. So when the patient is wearing the aligners, we have no mobility and we have quite stabilization. And I can plan the force on a certain point in a very, very minimal level. So you are right, but again, I think I'm right more. So you can see how we progress with this patient. Of course, it is very important to do scaling and cleaning on regular basis. I invite my patients, especially periodontal patients, to do cleaning every 4 weeks on a regular basis to keep teeth very clean, to have a good oral hygiene protocol. And you can see how teeth, not only spaces are closed, but even the papilla start to build more nicely and the roots become more parallel. You can see the before and now in the middle, and you can see how we progress with the case. We plan, as you can see here, the staging in a way that every movement is very, very minimal, is very, very accurate. I know exactly how much force I apply and on which teeth. And you can see now I am in a positive overjet, so I don't have trauma anymore. I do some follow-up x-rays to see that the bone is okay. There is even a little gain of bone because of the change of the angulation. And you can see the patient close to the end of treatment, smiling beautiful. He's now 71.5 years old in these pictures. And you can see that not only the aesthetic was achieved, but also the occlusion, overjet. Look at the papilla we gained between the front teeth, the lower front teeth. There was lack of papilla completely. We got a very nice papilla in the upper and lower aesthetic zone. And here are more pictures of the occlusion. And here we did some fixed retainers. What do you say about that? Now you regret that you didn't want me to treat this case? Well, I can tell you it's a wonderful results. I'm really, impressed by these results. But what about stability? Now he is class 3. He used to be in a negative overbite, and he has now, we retruded all the teeth, we minimized the space for the tongue, and we are in a very unstable position. What do you say about that? Well, I knew you are going to ask this question, and this is why I brought you pictures, 5 years follow-up after I finished the case in retention. And you can see that case is stable, case is very, very aesthetic, and patient is very happy. Patient now in these pictures is already 76 years old. How many patients we can tell ourselves that we did such a service, and you remember how he looked before and look how he looked now 5 years later. Everything is stable and hopefully will stay stable in the next 20, 30 years. Well, I want to present you, Rafi, another case because I want to challenge you. This is a lingual case. This patient came to me, to my clinic. She has deciduous primary cuspids, teeth number 53 and 63, and some malalignment of the teeth. And you can see here that we have 2 impacted canines. They are not only impacted, but they are also mesially tilted. One of them, you can see the left one is reaching already the palate, so we have some way to bond something on it, and the right one is rotated and also in the palate. So I've used a very, very simple technique to take the brackets and place it on the model. As you can see here in the movie, you can see that I do lines, I place the bracket, I prepare the tray in a very, very easy and not expensive way, which help us to minimize costs and use digital tools later if and when we need it. So you can see how we start the case. It's a very regular case. I use ORG brackets. By the way, I'm launching a new bracket which you can find in Peter Sheffield booth, which again is a simple way to do lingual treatment without the need for very sophisticated brackets. So we start rotating the teeth. In the right side, we didn't extract the primary tooth yet in order to do some rotation before the extraction. So we progress quite nicely. You can see slowly we are extracting primary tooth. We are bringing the cuspid forward. I'm taking records all the time, seeing the overjet is not increasing. Alignment is improving slowly. And you can see here the before, middle, and now. Well, what do you say, Rafi? I'm sure you have something to comment. You see, Rafi, you talk all the time about CAD/CAM. You talk about wonderful labs. And then you take and you place your brackets like this without any accuracy, without nothing. Look, the teeth maybe are better than before, but they are not aligned properly. Rafi, I waited for this question and you were trapped. And now you are giving me my lead to the next topic. Because I take digital as a concept, as a whole. So we started to do the alignment in a very simple, not expensive way. Now I can take the patient and move him into the digital platform. We scan, we move the scanning into 3D digital tool. We have now everything on the computer, including the brackets, including the virtual wires, because we didn't order wires yet, but we can see how the wires will look if we move teeth to a certain place. And now I can do the planning. I can correct all the angulations. I can correct all the occlusion. I can do even wires which are specific for a tooth with a different torque, a different angulation, a different inclination. I can do all the overcorrection into the plan. And this is something that you cannot do, because if you do all the laboratory, once you do it, you are done unless you take another impression. I can even order wires now which are in percentages, meaning that every time that I want to increase the force on a tooth, for example, you remember the periodontal case before, I can plan a wire which has 20%, 40, 60, 80 on a specific tooth in order not to apply too much force on the same time. So you can see this case, once everything is planned, once we put the digital robot wires which I've ordered from SureSmile, and look now how everything becomes more arranged, more aligned, how occlusion become better. And you can see slowly we do the upright of the lower incisors near the cuspids. And everything looks really quite nice. So we have decided to debond the brackets. Well, not bad, but as you can see, Rafi, still I have some, if to be really pedant, I want to see a wonderful, wonderful alignment, not only occlusion. And you can see there are slight little things that need to be corrected, even that you took off the brackets. What are you going to do about it? Well, I told you I'm doing a digital concept. Now, the digital concept allows me to go back to the planning, the digital planning that I've done, and to move all the teeth that need now a very, very small correction. And here you can see how I extracted a digital model from the digital software, printed it in 3D printer. Today, many clinics have 3D printers, and if not, you can send to a laboratory. And then I let the patient wear these aligners, which I've made in my office, which now act as a positioner in order to move this little movement that still needed to be done in a very simple way without the problem of occlusion. Because the cuspid, for example, the left cuspid did not get into place because of the contact between the lower teeth and the upper bracket. Now with the aligners we can do this finishing really, really quick. And here she is after 2 weeks, and look how her occlusion, her aesthetic, everything look really nice, really stable, and patient is happy. So I've concluded for you all the options in Lingual and Invisalign, and I hope you have enjoyed it. Thank you, Rafi, for a very interesting debate we had together. Oh, thank you, Dr. Rafi. It was really interesting. And thank you all for attending this lecture. I promise you to be with you in our next lingual meeting, and I hope you will enjoy your Wesley meeting in Thailand. See you.